more than 30 years experience in pulmonary and critical care medicine, and he is an associate professor at the University of Alabama in Birmingham. And tonight he'll be giving us an update on sepsis. But there will be another session on the 25th of August, and that session will be at a different time of 9:30, so half an hour later in RIA time, but whatever time that corresponds to yourselves. Just to let you know, the Advanced Mechanical Ventilation course will be conducted on August the 31st and September the 1st. So please visit the event tab on the website for details about registration. All educational sessions are available now under the tab Education of the website. However, you will need to be at least a silver supporter of our mission to be able to access them. So we just recommend again that if you're not already a silver supporter, that there's so many benefits included with being one, and we really appreciate everyone who supports us at ICU Reach. So now I'm going to pass over to Dr. Abhishala and let him take it away. Thank you very much.
Thank you, Grace, and thank you, Mazen. I'm really excited to share this information with you. Talking about sepsis and septic shock is a passionate topic. We see it very often in the ICU, and a lot of you, no matter what specialty you might be doing, if you're not already working in the intensive care, will be facing the different manifestation of sepsis. So with that, I mean, there have been some issues. I'm going to say it at the beginning and maybe say it at the end, is what we usually do in sepsis. So septic and in general, but you know, septic shock, we like to keep things perfused. We like to fill up the tank, and we want to get the pressure up. And you want to do all of these things at the same time, concurrently and quickly. So everything we're going to talk about is how can we do that? A septic shock patient, so somebody who's hypoperfused and hypotensive, and you're dealing with those patients in various manifestations, different phases of their illness, but that's sort of the bottom line. So I'll come back to this, and we're going to try to dissect how we can get all of these things done and how we can do it all at the same time. So with this, sepsis is not an easy disease to recognize. It may be very clear to sometimes when you have the classic knowledge of having the patient infected, having fever, and rigors, and have a clear-cut pneumonia, and then they gradually drop their blood pressure. This may be an easy patient to identify, but many times sepsis is a big masquerader of other illnesses, and sometimes we're not sure. So you want to err on making sure sepsis is in your differential diagnosis, particularly in those patients that present atypically, like those patients who present only with altered mental status, for example. Now, how important is sepsis and how we manage it? Here I'm trying to show you three different sort of scenarios. If you happen to work in an emergency room and you see these different situations. So one on the left is somebody who had a car accident, he's alert and his blood pressure is 130/60. The next is a patient who's having chest pain, he's 70 years old and he's having a STEMI. And the third one is a patient who's having cough and fever, confused, and his blood pressure, what people call it these days, soft. His blood pressure is 88/50. Now, when you look at these patients, you know, how do you imagine is going to be seen first? If you happen to be there and, you know, whether you're a nurse or a physician, who's you're going to run to see first? I know we're not doing any polling here, but, you know, if I were to bet, very likely most people are going to go to either the patients on the left with a car accident or the patient with the STEMI. And the last persons to be seen is a patient who's having cough, fever, and a soft blood pressure. And I'm not saying this is appropriate or inappropriate, but at the same time, I want you to be aware that the mortality of these patients, that person roughly about 5%, a patient with STEMI, it's about 10%, and that patients with pneumonia and sepsis has a 30% mortality. So that should make you think differently in the future when you deal with that. and it is urgent to manage sepsis as it is urgent to manage any of the other conditions, and probably sometime more important. So with this, the reason for preventing this confusion is that they have published several guidelines. And this is the history of the guidelines. As you can see it here, it started from 2001. It's usually published in both journals, the critical care medicine and the intensive care medicine. So European and the North American journals tends to publish the guidelines simultaneously. And as we can see here, the guidelines been about every 4 years, and then there were some updates. So 2016, you see here different bundles, and I'll mention to you why we use those bundles. And then finally, the last one was in 2021. And so we had in 2018, that was considered to be a supplement based on newer data. There've been a lot of debates and criticism for the 1 hour bundle. Then now we're back to the 1 hour and 3 hour bundles for managing patients with sepsis. So 2021 is the last guideline. Now, the terminology of sepsis, and I think some of you have seen this sort of progression from what we call it SIRS to sepsis, to severe sepsis, to septic shock. That terminology was brought in from the time, and I happened to attend some lectures with Dr. Roger Bowen, who's one of the fathers of critical care medicine. That was in 1992. And now the sepsis 3 sort of definition that was in 2018 decided to use two part. They said we only have sepsis or we have septic shock. So they took the other terms and they depended on definition of sepsis by using the Q-SOFA, the quick SOFA score. As you know, SOFA is the organ dysfunction. So if you had more than 2 out of the 3, we would use this. And then if you have hypotension requiring vasopressors and a lactate, after adequate fluid resuscitation, you would call the patient having septic shock. So that was the definition that was used since 2018. And now it looks like they changed their mind. So 2021, they said, oh, we don't like the quick SOFA, not anymore. We're gonna go back to SIRS. So 2021 now, and they came up with 93 new recommendations. And do not worry, I'm not gonna go over the 93 new recommendations, but they are sort of summarized in the first 2 to 3 pages of the sepsis campaign, and I'm sure any one of you can Google it, it's available for free. So now we have 3 terms. We have SIRS, which is sort of the pre-sepsis stage where you have manifestations of inflammation. You can have high, low temperature, tachycardia, tachypnea, or elevation or decrease in white count. And then you have sepsis, where you identify SIRS caused by infection. And then you have septic shock. And septic shock nowadays require that the patient has to be on vasopressors with elevated serum lactate. So hypotension, so the patient needs to require the use of vasopressors. So this is the new sort of agreement in the last 2021 guidelines. Now, just to be clear, we talk about hemodynamic instability. I wanted to define that because this is something we're going to deal with all the time when we manage sepsis, is parameters and goals for management. So hemodynamic stability has 2 parts. One has to do with the blood pressure, and the other one has to do with the perfusion. So hypotension, tachycardia unresponsive to treatment, orthostasis, patient has to have multiple fluid boluses to get the blood pressure, or the use of vasopressors to maintain adequate blood pressure. All of these will go in the category of what we call it BP related. Now, parameters of inadequate perfusion is the other part that you can say the patient is hemodynamically unstable, and that's a blood test could be lactic acid, prolonged capillary refill time, reduced urine output, altered mental status, or someone who has mottling and hypoperfused lower extremities and cold. So as you can see here, there's part that has to do with things you can measure, which is blood pressure and heart rate, or these are things that you can do either as a blood test, as a parameters of perfusion, adequacy regarding organ function. Now, how do we do this on the bedside? And this is oftenly missed. And I think I'm noticing now our resident are recognizing these things much better. But feeling, when you go inside the room, you want to touch the patient's skin, you want to feel their hands, and you want to feel their feet, and you want to look for mottling. So having someone who has cold hand or cold extremities, the tip of the fingers, we do what's called the capillary refill time, and then the mottling. And I notice even in the most recent publication that were presented in Belfast, they used the mottling score to identify the severity of hypoperfusion and sepsis. So this is where you look at it over the kneecap and how extensive is the area of mottling. Now, if you want to get sophisticated on the right side, you could do what's called the T-skin, called T-central to peripheral. Simply, if you put your hand on the patient's chest and you put your hand on the patient's hands, and you can feel a difference in temperature, that's a sign of hypoperfusion. You can look at the oximeter itself. The waveform on the finger can also give you an idea about the perfusion because it tends to be reduced. The waveform tends to be more dampened. And there are some more sophisticated near-infrared spectroscopy, but I'm not sure these are available worldwide. So with these parameters, these are things you can walk in the room, touch the patient, look at them, and then tell whether are they having signs of hypoperfusion, how sick they are. Now, so this is a sign. I'm trying to show you the biggest manifestation. This is a patient who has significant mottling. This would be almost grade 5 because we're going beyond the kneecap all the way up to the upper thigh. And this is the same patient after adequate resuscitation. You see how the skin looks beautiful, pink, and well perfused. But this is, but this mottling is important to recognize, and it's sort of, you can use your ways of resuscitation to monitor the response of that patient. Now, this has been done in a scientific way. So one of the papers that was published in the New England Journal of Medicine looked at capillary refill time versus serum lactate. And in a lot of places, you may not have the capacity to do, serum lactate every 4 hours, particularly in some, developing countries where lab limitation and timely lab is difficult to do. So you can do this very simply. And this study looked at a resuscitating strategy targeting peripheral perfusion status versus serum lactate. So you can do the finger check and you do capillary refill time. You put a good amount of pressure. They describe it in the paper. You do it for 20 seconds. You make the finger tip blanch, and then you let it go. And then you look at how long does it take to get the tip of the finger to be pink again. And in general, it should be less than 5 seconds. So this is, and the longer it takes, the worse is the hypoperfusion. So this study was called the Andromeda shock. And they compared, if we did this for patients every 4 hours, and we looked at capillary refill time, and actually you can do this every 2 hours if you want. This is a bedside examination. And then you look at, is it as good as just keep measuring serum lactate every 4 or 6 hours and then correlate that with the outcome. So this is what how the study was conducted, comparing serum lactate serial measurements with patient response to resuscitation. So if we look at it here, the study had about 400 patients, about 200 in each group, and the intervention was comparing capillary refill time with the patients doing serum lactate. And if we look here at the outcome, these were 28 ICUs, 5 countries in South America. The study shows that if you do this and you look at the cumulative mortality, it appears that peripheral perfusion group did a little better, but there was no statistical significance. But again, the mortality was 35% versus 43%. So this is a very simple thing. I always suggest that we should do this routinely. Nursing can be very helpful in looking at that and saying, capillary refill time is not improving. We need to do something else. We may have to consider our method of resuscitation, the amount of fluid, the type of inotrope, and so forth. But this is a very simple bedside measure, been scientifically proven to be as good, if not better, than serum lactate. And I bet you it's underused. So here's a quick question before we move to the next, which is, making that think, which intervention directed to treat patient with septic shock has the strongest impact on survival? So early triage to a high volume center, early appropriate antimicrobial therapy, starting corticosteroids, and blood sugar control. And again, I don't think we're set up to do question answers or polls on the system, but the idea is, if you see a septic patient, do you feel the most important thing is to send them to a referral center as soon as possible? Or would you like to start them on antibiotic right away? Or do you think steroids would have the most impact? Or do I need to make sure his sugar is well controlled? As we know, almost most patients with sepsis and septic shock have hyperglycemia, even if they're not related to, if they don't have any diabetes. So the correct answer for this is going to be early appropriate antibiotics. And now we're going to talk about this later, maybe in the part 2. I'm not sure how much time we will finish today to talk about initial resuscitation and infection issue. So the guidelines are divided into 3 parts. One is related to how we should resuscitate patients and take care of the infection. How do we provide hemodynamic support? And adjunctive therapy is things that might be helpful, like the discussion usually raised: steroids, vitamin C, CRRT, other methods that might be helpful to in patients' outcome. And then you have other supportive therapy is sort of the optimal care in the ICU. So most of the stuff that we will discuss in today's is going to be related to how we initially resuscitate patients and manage infection issues. So with this, let me show you what is called the sepsis bundle, and I'll tell you what's the background behind that bundle. So the sepsis bundle is looked at these parameters, which is measure serum lactate serially, at least every 6, do blood cultures before antibiotics. The yield of blood cultures doubles if you do it before. And there are some studies that show that if you gave antibiotic, don't discard the idea of doing blood culture. They're still helpful, probably more like in the 20% range if you have somebody with bacteremia, compared to about 40% range if you did it before antibiotics. You want to give your antibiotics within 1 hour of the ED. That's the early sepsis bundle. We're going to discuss that later because there's some modification now. And then you want to do fluid resuscitation. The recommendation based on the study that I will discuss next is 30 mL per kilogram for hypotension or lactate more than 4. Use vasopressors for hypotension if they don't respond to fluid. Maintain adequate CVP, maintain adequate SVO2. That's again taken from the early goal therapy study that we'll discuss next, and then keep measuring serum lactate. So this is sort of the initial bundle. Now, when we look at that, the reason I wanted to mention this paper, because it is cited so many times, and I'm sure when I did this, there are a lot more citing articles. This is a study by Emmanuel River, mainly done it was done in Detroit. And they have a very large volume, very large emergency rooms. It was an ER study that looked at early goal-directed therapy in the treatment of severe sepsis and septic shock. So this early goal therapy has sort of taken the practice of ICU after this publication to the point that is, when we look at what happened afterward, the culture have changed using what has been done, but not every step of it. So the study looked at interventions. So if you have hypotension, meaning systolic blood pressure less than 90, after initial fluid bolus, your lactate more than 4, so you have septic shock. And that's the inclusion criteria. And these patients received fluid, vasopressors, and transfusions or dobutamine, depending on these parameters. I will not dwell, I'll go through the details for purposes of time. They used a central line, and they use a continuous oximetry through the central line to measure mixed venous saturation, which is something we don't do these days. And then we can see, so when they did the whole protocol, the early goal-directed therapy, managing them, targeting fluid, initial bolus followed by reaching high CVP, giving them vasopressors for a MAP more than 65, and then targeting a mixed venous more than 70%, these patients did better. They did quite much better. That you can see here that the mortality reduced from 47% to 31%. So this is almost 16% difference. That gives you a number needed to treat of 7. So there was a very astounding study that made all of us who were practicing at that time feel that we're compelled, we have to follow this protocol. But for some reason, we didn't follow every part of the protocol. And then people start questioning, do we need to do the whole 6 packs? Or can we do a little bit of this? Can we modify it? We always, people are rebels, they don't follow exact guidelines. But, sepsis management did get better. And this study have shown that there is a significant reduction in mortality if you follow the early goal therapy. So after this, because people questioned, and if you look at our real practice, we really never sort of did a mixed venous continuous saturation central lines. We didn't. Some people did, some people did not. So the idea of targeting a hemoglobin of 10, which at that time we had studied to show that 7 was adequate, and then titrating our cardiac output based on mixed venous, and then using dobutamine, all of that was part of the bundle, but was not used most of the time. So these 3 studies, the ARISE study, the PROCESS study, the PROMISE study, were very large, randomized, as you can see, US, UK, and Australia, looked at, do we need every part of this protocol? So they did what's called protocol-based standard therapy, and they did protocol early goal therapy, which is exactly how Emmanuel Revel did his study. And what it showed that there was no benefit, as you can see here in the previous slide, the mortality was the same, whether you use the protocol-based, which is early goal, and doing exactly what was done in the Emmanuel Revel study versus leaving the physician to do the usual management. Now, we need to keep in mind that the culture have changed, and people already done this fluid boluses, they already started early inotropes. So to be fair to the study, now we're looking at it years later, people change their practice. So people did look, because all of these were well randomized studies and done at university centers. So there was a prompt recognition for sepsis. They did prompt IV fluid for hypotension. People were resuscitated early, and they gave them antibiotic very early in the course of early septic shock. So in those settings, it really, after that, it seems it doesn't matter if you do mixed venous, it doesn't matter if you target a hemoglobin of 10, if you use dobutamine, all of these issues would not be the most important, and it did not show any difference in outcome. So in 2021, we can say that we need to follow these 3 things because these are established: early recognition, prompt IV fluid, and prompt IV antibiotic. And we can show later the importance of each one of those. So as you can see here, these part of the bundles we still use. We do want to measure serum lactate. We want to do remeasure it. We want to do blood cultures. We want to give antibiotic quickly. We want to give fluid resuscitation. We want to use vasopressors, but we don't need to follow CVP. We don't need to follow mixed venous oxygen saturation. Now I want to talk a little bit about for septic shock and using fluid. Now, fluid is, we have so many options when it comes to using fluid for patients. That's became a little bit confusing. And so for this, I wanted to say, what would a fluid bolus do to the patient's hemodynamic status? When you say give the patient's fluid bolus, and in general, I usually always discuss on rounds when I tell the resident, if you want to resuscitate someone, don't give them a continuous infusion because it is worthless. Continuous infusion is for correcting electrolyte imbalances or maintaining the patient fluid status. But if you want to challenge the patients, if you want to improve with it, you have to always use boluses for that. So a bolus in the range of 250 to 500 mLs is going to raise the stroke volume by about 10 to 15%. But keep in mind that less than half the patient respond to fluid. So that's why most patients with septic shock end up in the ICU, because otherwise we would not see them. So about 40% may respond to fluid, and that's the end of it, but about 60% or more will be requiring vasopressors and coming to the ICU. Now, with this, that hemodynamic effect of fluid bolus is short-lived. We know fluid tends to dissipate in the interstitium and get out of the intravascular tree. So 15% of crystalloid remain intravascularly at about 3 hours. And then if you do too aggressive fluid resuscitation, it increases mortality. So that's issue. I will hopefully touch base on it as there's a big talk about de-resuscitation and being conservative in fluid management. And I think there are some new information that came out recently in this that I will share with you today. So with this, if you look at the recommendations now about using IV fluid, we see here that the initial fluid challenge usually is about 1 liter. That's what the guidelines recommend. And they want you to use about 30 mLs per kilogram of crystalloid in the first 4 to 6 hours. So it used to be that it was a strong recommendation before in 2016 and 18, but now it became weak recommendation. So it's not like you have to give 30 mLs per kilogram because, based on review of the data and going back to the early goal therapy where this number came up, is no longer felt to be a strong recommendation. So it's a weak recommendation 2021. The recommendation continues to say use crystalloid as the initial fluid for resuscitation. You could use albumin, but it is a weak recommendation. There was a point in time in the guidelines say don't use albumin because there was early trial that showed higher mortality, and now we say no, you can use it, it's safe. And then I don't think these are any more available. There were several papers that showed worse outcome if you use these hydroxyethyl starches with the high molecular weight. So that's a strong recommendation not to use. Now, the reason I wanted to share with you this paper, and I think it was discussed in the Belfast meeting, is why do we care about fluid? And why the pharmacist is going to point to you and say, why are you using albumin? So if you look at the cost, and this is a study that looked at the international comparison of the cost of fluid resuscitation therapies. The normal saline, this is the cost for about 100 ml. Normal saline costs about less than $1. What we call them the other fluid, the electrolyte equivalent fluid is about $3 to $4 per 100 mLs, but albumin is roughly about $59 to $60 per 100 mLs. So you can see, and since fluid is the major management issue that gets done in hospitals, so you can see how from a hospital administration cost efficiency, it makes a huge difference if we use albumin for resuscitation versus normal saline versus other type of fluid. But when it comes to outcome, it's still also important. It doesn't make a difference in outcome and mortality. So here I wanted to compare, what is normal saline? And I think that a lot of people say there's nothing normal about normal saline, because if we look comparing our plasma composition compared to the normal saline, we see the sodium is higher. The chloride is the major problem with normal saline, is that it's very high in chloride because it doesn't have anything to buffer it. And the osmolality is a bit higher, and it is acidic. So Ringer's lactate seems to be closer to real plasma. The sodium is a bit lower, but the chloride is closer to the normal, and it has lactate in it. And that, by the way, is not usually a problem inducing more lactatemia in patients. A normal person should be able to metabolize the serum lactate and becomes bicarbonate. The osmolality is closer to normal, so it's a little bit, definitely more physiologic to use Ringer's lactate. Plasma light is sort of the equivalent of plasma in many aspects, as you can see here, but it is a lot less available and more expensive. So now, if you look at these is called the balanced fluid versus saline in critically ill. This is looking at the evidence. Now, there have been many papers published looking at outcome if we resuscitate patients. And these studies, most of them were first not randomized, and two, they included all critically ill patients, not specifically septic patients. So if you look here, this is a negative study, no difference. This is a negative study, it's called the SPLIT trial. This is a SMART trial, which was positive in 2018. Basic trial 2021, the plus 2022, and the meta-analysis here. So these were various sort of looks at whether it makes a difference. And I think the only true randomized trial in patients, in general ICU patients, was the SMART trial published in New England Journal of Medicine 2018. And this is the one that I will share a couple of slides on this one. In this one, they compared balanced crystalloid versus saline. So balanced crystalloid could be plasmolite, or it could be Ringer's lactate. And this is called the SMART Investigator. That was published in 2018. And this study, if you look here and you dissect about the type of patients and whether they had sepsis, yes or no, and you look at the odds ratio favoring balanced crystalloid versus saline, we'll see that it is statistically better to give patients who have sepsis balanced crystalloid than to give them normal saline with the odds ratio of 0.8. So almost like a 20% reduction in mortality based on the SMART trial. And that's probably so, and the number of patients were quite good. I mean, you see here that those with sepsis, 395, 455. So it's a good study to draw a conclusion from it. And for that reason, when I tried to look at recommendations, for example, this is the anesthesia critical care and pain service, looked at choice of IV fluids for vascular filling in critically ill patient. This is 2021 guidelines. And the other question is, inpatient with sepsis or septic shock, does use a particular crystalloid solution help to reduce morbidity and mortality? So their recommendation is use balanced crystalloid for fluid resuscitation rather than normal saline, and they give it a strong agreement. And when I looked at their rationale, it has to do with looking at that specific paper. So I won't say that the evidence is the strongest, but I think the price is very close to each other. And a lot of us practicing in the ICU now favor Ringer's lactate or balanced solutions if they're available, like plasmolite over normal saline. Now, the problem of fluid resuscitation is fluid overload. There's no question that almost every patient we see with sepsis end up being fluid overloaded. They swell up, and that's what probably those of you who round and see family, they always tell you, why is my father or my mother are swollen up so much? And that's one of the reasons. The moment I walk in, and sometime I had one patient had the ring, and I reminded the nurse, you need to take the ring off because tomorrow you won't be able to take it off. So this is a problem. You swell the patients. If it looked like that Michelin man, and that's quite common in sepsis. So there's a principle, I think it was published by Dr. Jean-Louis Vincent. He called it the SOSD concept, that as initially in a septic patients, you initially when they're in the state of shock, you want to salvage them. You want to keep them, alive. You want to resuscitate them properly. So that's where you use fluid vasopressors. If you have somebody with massive pulmonary embolism from shock, you give them thrombolytics. It's called the salvage stage. And in this stage, almost all patients get too much fluid. The optimization phase in the management of sepsis is where you want to get the patient to the right target. That's where we start doing capillary refill time. Say, am I giving enough fluid? Am I giving enough vasopressors? Should I optimize the antibiotics? It's called the optimization. I got cultures back. And then the stabilization phase is when you keep them from having organ dysfunction, particularly, are they waking up properly? And these patients, do they have renal failure? Do I have adequate perfusion to the kidneys? Do I need to dialyze and remove fluid and so forth? And then finally, the de-escalation is where you start cutting down And then when it comes to fluid is the time when you want to get rid of the extra fluid. So sometimes you either dialyze, or most of us would use diuretics when the kidneys still function. So in this situation, this sort of concept, people talked about maybe we could avoid too much fluid, so we don't have to go through this over resuscitation, then de-resuscitation. And that's a term that you'll see called de-resuscitation in sepsis. So this is one of the studies that looked recently published. I believe it was also presented at the Belfast meeting through care reviews, about published from the New England Journal of Medicine, is restricting IV fluid in septic patients improves outcome. So that was the question. So the study was published here in New England Journal of Medicine, and these all were septic shock patients that were on vasopressors and had elevated, and they called the classic trial group. So this study looked at restrictive therapy, and they had a large number of patients, 770, almost in each group. And those patients, and I'll show you their protocol. So if the patient get randomized to the restrictive therapy group, these patients would get a bolus initially of 250 to 500. This is the one we discussed earlier. And then you don't give them any fluid. You just give them vasopressors. If you see signs of hypoperfusion, and they define it in their paper as having prolonged capillary refill time, or they have mottling that is worsening, then you give them more fluid. But otherwise, you don't. You just give vasopressors, and you give them limited amount of fluid initially before that. And then if these patients can't be given, so then you sort of give them whatever they need if you think they're dehydrated, or you need to give them maintenance fluid to maintain their adequate fluid intake per day. Now, in the liberal strategy or the standard therapy, these patients had low limitations, so they could get whatever they want. So 30 mLs per kilogram, they can continue to resuscitate with fluid based on hemodynamic parameters. So they left it up to the physician and the healthcare team to give more fluid. And there was no limitation on that side. So if you look at the death at 90 days, this is looking at restrictive therapy, where you basically use a lot more vasopressors and less, and then the standard therapy. And there was absolutely no difference in mortality between the two. Patients' outcome was the same. So giving the patients seem that restrictive therapy is safe. If you can look at it either way, if you are from the group that believe in restricting fluid, you will say, well, restricting fluid is good. The patient did not have excess mortality. If you're one of those people who like to give more fluid in general, you'll say, well, see, I told you so. You don't have to restrict patients' fluid because the outcome is the same, and giving them too much fluid is not detrimental to their outcome. The problem with this study is the amount of fluid. And again, I always say culture change make people practice. We've been talking about restricting fluid for so many years that these patients in the group did not get too much fluid in either group. So the standard fluid group, in my mind, and in many people that looked at this study, felt that they were getting restricted fluid anyway. So the difference between the two in the first day was 700 mLs, and that's the median or the mean difference between restrictive versus standard. If you look after 5 days, there was no difference. If you look at 90 days, 2 liters. So I would say 2 liters is not going to make a difference in outcome in these patients. What we've seen sometime in real practice is a patient who gets 5 or 8 or 10 liters at the first day, and these patients get really blown up and then get very edematous. And that, I feel, many times inappropriate because people do not want to use enough vasopressors and so forth. So I think this debate is, the paper says restricting fluid is equal to liberal or traditional approach of giving fluid. But I want to remind you from analyzing this paper that the difference was too small. So I think in both groups, they did not get too much fluid. I think the best way to manage fluid is to look at dynamic assessments, and that's been recommended. So that's one of the ways is to do stroke volume variation measurements. A lot of the simple bedside equipment, if you insert an arterial line, which is recommended by the guidelines of sepsis, is in any patient require vasopressors, put an arterial line so you can do invasive hemodynamic assessments, and looking at the waveform of the arterial line, particularly with those machines, would help you to define whether they have stroke volume variation. So this is one of the ways to look at it. So if you look, this is called the Frank-Starling curve, preload versus the patient's cardiac output. You see that those patients who have significant stroke volume variation, if you look at their arterial line, you see significant fluctuation with breathing. These patients are usually fluid responsive, and giving them more fluid would bump their cardiac output, and it's called fluid responsive. Whereas if the stroke volume variation, that fluctuation in blood pressure over time is less than 10%, these patients are unlikely to respond to fluid, and you should concentrate on just using vasopressors. So that's actually the real way to do this. This is more accurate, and it's not available to everybody, but if you have an arterial line and you have this simple equipment, this is called dynamic assessment. Now I want to move to a couple of things. One about timing of antibiotics. We will not discuss the antibiotic choices as it vary based on the patient's cause of sepsis. And most places have protocols based on their antimicrobial resistance. But how fast do I need to give the antibiotic? So this is one of the early trials in 2006, is still being quoted, that looked at timing of antibiotic and survival. So if you look here over time, this is 0 to half. And then as you move down over, the longer the patient received, and this study looked at appropriate antibiotic, not just any antibiotic, because in hindsight, you look back at the cultures. So getting appropriate antibiotic, the later that you give antibiotic, particularly after that 6-hour window, the mortality really becomes dismal, and the outcome is very poor. Now, when we look at percent of patients receiving antibiotic, it is, shameful to say that about 50% of patients in septic shock at that time in 2006 receive antibiotic within 6 hours, and they did have septic shock. So with this, I want to say that, now that number here that you see sometime, what people call it 7% per hour, is probably not accurate. There are more data, newer data that I may share with you in the part 2, that the real number is probably 3 to 4%. So every hour delay in antibiotic would increase mortality by 3 to 4%. So it matters when you give antibiotic. So what happened is, in the new guidelines in 2021, they sort of gave us a summary about how to deal with antibiotic timing. Now, in 2018, I remember I mentioned to you, they did the supplement to the guideline. They did the 1-hour window. They said, you got to give antibiotic in the first hour. What did that make? That made particularly ED physicians, because of fear of, having their hospital being reviewed and not meeting the proper criteria, government criteria, because it became almost like a government mandate. Everybody that comes in hypotensive, everybody with fever, everybody with suspected sepsis were getting antibiotic, and that led to overuse of antibiotic. So I think, and there are some studies that show that you really don't have to give it in the first hour. So now it's sort of dissected. If the patient have shock, is present or absent. So if it's not absent, it says give antimicrobial immediately, ideally within 1 hour, but you have up to 3 hours to give the antibiotic if your patient is not in shock. So within 3 hours, particularly if you're in the ED where you have the capacity to do all the tests and the white count and the chest x-ray, urine cultures, and so forth, you should be able to figure out in 3 hours whether your patient is infected or not. So 3 hours window is acceptable. If you have shock, they would like you to give that antibiotic within 1 hour of recognition, and that's a time window. So now we have a sort of separation between shock present, shock not present, to give antibiotic timely. So now I know we have the next 10 minutes. I want to talk a little bit about hemodynamic support. Now, when it comes to hemodynamic support, I'll give this example here of a patient and see, how we choose vasopressors. One of the common things we hear from probably, colleagues in medicine is that we can't tell the difference between vasopressors. And I usually like to say it's really simple, and I'll hope that I can explain it well in the next slide. So if you have this patient who has septic shock, somebody started a vasoactive drug. And then this is the patient's numbers before and after the vasoactive drug. You see here before cardiac index 4.5, 4.2 after the drug, heart rate 115, 110, mean arterial pressure 59, and increase to 65. So this is a vasoactive drug that worked and led to an increase in mean arterial pressure. But what drug is it? Is it dopamine? Is it dobutamine? Is it norepi? Is it vasopressor? So if you notice here, so one of the things we look for, because all of these have different effect, they have alpha, beta, and sometimes neither. That's why you can look at heart rate. There's no change. There's no change in cardiac index. So this must be one of those drugs that have no impact, doesn't have any beta stimulation. So dopamine, dobutamine have beta stimulation, norepi have beta. So the only drug that would fit that pattern would be vasopressor. So I usually have this slide that I'm hoping that this will make things very easy for you. So you start from isoproterenol, which is a pure beta, and you go to dobutamine, mainly beta, or actually only beta, then dopamine, which has mixed, depending on the dose, epinephrine, alpha and beta. Norepi is predominantly alpha, but a little bit of beta. So you do get some tachycardia when you use high doses. Phenylephrine is a pure alpha, so a lot of time, but however, none of the guidelines in sepsis recommend that you use phenylephrine for management of septic shock. The only way I can see it is in patients who's getting severe tachycardia. And then we can talk a little bit about this later, but phenylephrine is one enough, but it's the only pure alpha. Now, vasopressin, on the other hand, does cause vasoconstriction, working on the VIP receptors without having any impact on heart rate. So with this, the recommendation is to use norepi as a first choice. This has not changed for any of the guidelines from 2016 till 2021. It always says strong recommendation, norepi. Vasopressin as an adjunctive treatment, 0.03. And there's a debate about when to add it. I usually like to add it if I'm using a high dose of norepi. My high dose is considered 0.3 mics and more. Some people think we should use it earlier. There's a big debate. So, but it is a weak recommendation. Now, certainly if I'm using norepi and I'm getting tachycardia, then I would add vasopressin to minimize the dose. Now, epinephrine would be the second line if you have a patient, particularly when you have suspected secondary cardiogenic shock. You can get cardiogenic shock from sepsis, or you can have cardiogenic shock from someone who has already pre-existing heart failure. So epi would be the next drug. The problem with epi, too many arrhythmias and a significant tachycardia. And I think all the guidelines throughout the years now, strong evidence, do not use dopamine. And I think I haven't used dopamine for many, many years now. There are very, very few reasons to use it. People think that you can use it peripherally at low dosages, but now we know that norepi can be the same. Dobutamine is a tricky drug. I've had more failure with using dobutamine than benefits, but supposedly when you have a low cardiac output, particularly with patients with pre-existing heart failure, first you need to make sure it never started alone, and never started at the beginning, because you're going to make your patients more vasodilated. It's a beta agonist, but it's a vasodilator. So it is one of those to add on to norepi if you still have a low cardiac output parameters and hypoperfusion, and you feel the patient's IV fluid status is adequate. So so if you notice here, the term in the 2012, they always reminded us, use vasopressors early. In my early training say you can't use vasopressors until you give enough fluid. Now it says is even when hypovolemia has not been resolved. So you do it in conjunction. Remember the term I said in the first slide, do all of these things, fill up the tank, get the pressure up, and do it concurrently. So you don't need to wait for all the volume, the 3 liters that you wanted to give to the patient to say, I'm not going to start vasopressors. Usually the holding factors for using early vasopressors is where the patient is located and whether it's available to you. So if you were on the floor and your patient crashed and you don't have a central line, many people would not start vasopressors. And I think that's probably going to change based on what we're learning these days. So with this, 2021 said that the same thing, use it even when hypovolemia has not been. Now, here I'm showing you this cartoon to explain why vasopressors would help you to reduce the amount of fluid needed. So as we know in sepsis, physiologically, the veins get dilated. So we have venodilatation or vasoplegia. So your capacitance increase and your blood vessels get bigger. So you need more volume to fill them. And that's why you end up pumping fluid. And you sometimes imagine, where's this 8-10 liters of fluid that I gave to the patient go through? Because now you have bigger vessels. So in order not to give too much fluid to reach that tank to get the blood pressure up, you can squeeze that blood vessel, so you make it more constricted. So now it goes back to the normal volume, and I need a lot less fluid. And that's the rationale of using vasopressors, is sort of causing some degree of vasoconstriction, so you don't need to use that much fluid. And that's the idea of doing both at the same time in conjunction. So you don't want to use norepi in someone who's hypovolemic. That would be bad. You don't want to use too much fluid without vasopressors, because you end up drowning the patient. So now, what target blood pressure? These are the two questions that come up to vasopressors. And now here I'm trying to clear the debate. And how soon should we use vasopressors? So timing and target. Now, the traditional target has been listed above 65. That's a number based on early trial that looked at outcome, brain perfusion, and renal perfusion. And then I think that's been challenged with a large study that I feel it's sort of not well used, called the 65 trial. So the 65 trial is a study that talked about how to give less vasopressors to elderly shock patients. So 65 meaning the patient had to be over 65 and had to have septic shock. And they randomized these patients to what they called the study is called effect of reduced exposure to vasopressors and 90-day mortality. And they called it the 65 trial. And this trial said, okay, instead of aiming for the traditional, because anytime you tell the nurse, I want blood pressure 65 and above, that means she's going to aim for 65 to 70 or 70 higher. So this study said we're going to aim for 60 to 65 versus 70 to 75. So this is how you can randomize a patient and have enough difference to tell if there is any change. So if you notice here, the average patient in the trial that got the lower blood pressure was 66.7, and you see the range, versus the other group that got a map of 73 average, and this is their range of blood pressure here in that group. So they did have a good separation between the two. And I remind you, a lot of these patients, all of these patients were above 65, and a lot of them, more than 40%, had hypertension. So when we look at the outcome of these patients, there was no difference in mortality. So they call this permissive hypotension versus usual care. Mortality was the same, and actually there was about 2% less. These patients had a lot less need for vasopressors. These patients had a lot less fluid received, and they did the same. They have the same mortality with, and I wanted to say the third issue is there was no increased renal failure between these patients with the permissive hypotension, despite the presence of chronic hypertension. So I think based on this study, and I think now the guidelines have talked about it, but not clearly, but 65 is acceptable. And I think we're working on changing our target in blood pressure and using 60 to 65 in any patients who has septic shock or any state of shock, because that seems to be acceptable outcome with reduced need for vasopressors. Now, how soon you want to give your vasopressors? And that's also a debatable issue been raised is, should I give the fluid and start vasopressors? Should I do it very early? So in my previous presentation, I was reminded by one of our former fellows about one of the papers that was published recently. But before I go through that paper, I want to tell you what the guidelines say. So the guidelines tell us use norepi, use a target of 65 now. They're not saying higher than 65. So that's a 2021. Now they're telling us you can use vasopressors peripherally. And with peripherally, there is sort of a mandate here. And we discovered recently that they have a typo in the guidelines. So when using vasopressor peripherally, they should be administered only for a short period of time. And in a vein should be distal, not proximal, to the antecubital fossa. But that's a typo in the guidelines. So meaning you can run a peripheral levo-fed in a patient, and that's their recommendation. That's the idea of using vasopressors early. And then here they talk about, so they want you to use this in the first hour. That's what the guideline recommends. So after the guideline was published, there's a paper that caused a little bit of confusion. This is a Korean Sepsis Alliance investigator, and that looked at vasopressor initiation within 1 hour of fluid loading is associated with increased mortality. And it can cause a problem. It's published in the Clinical Care Journal in April. But I want to remind you, this is not a randomized trial. This is a prospective, multi-center observational study. So this is administrators looking at huge database, and they cleaned it out and they said, we're going to do this propensity score and compare patients that have the same severity of illness and see with those who received vasopressors in the first hour, because the physician felt he wants to give it in the first hour, versus those who received it later. Does it make a difference? When you look at the study, it appears that mortality was higher. So if you look at the early vasopressors, they have 48% mortality. This is a Kaplan-Meier curve, and this is 34% mortality in the late vasopressor. So if you were to take this data and accept it, you would say early vasopressors is detrimental. We should not do this. And they talk about their rationale and delaying fluid. But I think I want to remind you of the same problem with propensity scores. And first, this is administrative data. This is someone who looked at it, and they were forgetting the confounding factors. And I think the simple factor is when the physician decides to give vasopressor, that means he sees the patient on the bedside sicker. The same thing happened with the PA catheter. And years ago, there was an editorial say PA catheters are killing people, because they did this, again, propensity score and showed that patients that had PA catheter more likely to die. So people thought the PA catheter is killing them. They were not dying from complication of the PA catheter. They were not dying because of pulmonary artery rupture or infections. They were dying because the doctor thought they were sicker, and that's why they got the PA catheter. But that's not there. It's hard to do when you don't do a true randomized study to do a propensity score. So I don't think we should take that paper and say we should not use vasopressors in the first hour. So with this, I think I will tell you that there are two papers that are, or two randomized studies. We're waiting on them to, they started recruiting patients. This is called the ARISE fluid. This is the same group that did the ARISE study. So this is Australia, New Zealand, and this is the EVIS study, which is the UK and Ireland. I believe they also started recruiting, and this is looking at a randomized control study of using early vasopressors versus fluid. So I'm excited to, one day we can hear the result. These will be the true prospective randomized trials. Meantime, I would say we should continue to use vasopressors early. With this, I think time is we will go to the next slide here. I'm going to skip that. These are the other supportive care that we're going to discuss in the next part 2. And I want to finish again with what we discussed before is you want to keep things perfused. I hope I tried to clarify how we measure signs of adequate organ perfusion from what we can do on the bedside examination and maybe some other advanced testing that is available to us these days. You want to fill up the tank, so giving adequate fluid. All the studies that I've showed you have given the patients at least 2 to 3 liters before they were entered in the trial. So giving the patients enough fluid is always a paramount importance, and it should be done first. And then get the pressure up, and it seems that a MAP of 65 is adequate and shows as good outcome as higher MAPs. And do everything that I discussed before, do it concurrently and quickly. So with this, I will stop today and see if you have anything that came up, any questions.
Great. Thank you so much, Dr. Abushala. That was a very informative chat tonight, and it was both easy to understand but challenging at the same time, and making us think more about the different studies. And also, I was very glad to hear you mention Belfast a few times. I'm joining you from Belfast right now, so it's great to hear about the different research that was presented there. We have a question in the chat so far, but I'm also going to ask if anyone else has any questions, either to put them in the chat or you can raise your hand. and unmute yourself and then ask them directly to Dr. Abushala. But the first question is from Dr. Shafi. Hello, my name is Dr. Shafi from Tanzania, East Africa. My question for you is, how long should we keep patients on vasopressors when they have a poor response?
So let me say it again. So the question is, what do I do, or how low, or
so how long should we keep patients on vasopressors when they have a poor response?
Well, I mean, I think it's how long we continue the vasopressor if they have a poor response. I mean, the idea is sort of the escalation. If we're talking about a patient not reaching the target blood pressure with my Levophed, and I'm reaching a higher level and reaching, as I mentioned, maybe 0.3, 0.4 mics, so this is what I add another vasopressor. Now, I think if I'm reaching very high levels of vasopressor, the patient is not responding, then I have to do more dynamic assessment, where maybe this patient does need more fluid. Maybe I have to use epinephrine. So that's where the role of bedside echocardiography would be helpful to help us. And then some people are quite advanced in doing echo measurements and be able to tell what things might be helpful to the patient. But that's how I would use it, use the other vasopressors and check for other parameters.
Thank you very much for answering that question. I'm just looking through to see if anyone else has their hand up or wants to ask a question. So another question that has just been asked. Thank you for the very interesting lecture. My question is, have you ever used methylene blue in septic shock? And that's from Dr. Osama.
Okay. Only one time I was seeing a patient, and actually I don't know if there's any, I heard there's a randomized trial, but I haven't seen any publication that I was seeing a patient who was in septic shock in the cardiac ICU. And I remember the cardiac intensivist would use methylene blue on that patient. So I think they use it for what they call vasoplegia, and the patient had a good response. But it was more of a post-op cardioplegia rather than septic shock. So I'm not aware yet that there are any really studies in septic shock. Certainly would be interested to know if somebody have seen a publication that field, but I didn't see it ever mentioned in the guidelines to be used. But I've seen it in post-op cardiac patients, and I've seen some dramatic results with it, but I think it's more related to the vasoplegia that we see post-cardiac surgery rather than septic shock.
Thank you for answering that question. We have another question with Hassan, who has their hand up. So if you want to unmute yourself and ask.
Yeah, hi. It's a comment rather than a question. Hi, Nabil, good to hear you over the waves. Excellent talk as ever. Thank you very much. It's just to answer our colleague from Tanzania. I mean, further to what Dr. Abushala had said, quite rightly, this patient already into refractory shock. And here we have to consider any reversible cause, as Dr. Abushala was saying. So you need to make sure that you filled up the tank, maybe reach out to your echo or have advanced hemodynamic monitoring device to check, am I dealing with the pure distributive shock, or is there an element of hypovolemia, or more importantly, and commonly get missed, an element of cardiogenic shock? And here probably you need to add an inotropic agent in addition to your vasopressor agents. Having said that, the mortality is quite high once you reach to norepinephrine 0.6 mics per kg per minute associated with multi-organ failure state or a SOFA score more than 7. So there's some evidence to support this, and the mortality goes above 90%. So if you are in an area, where it's a low resource country, then probably I would stop at that level, keep pushing hard, because I know my patient is not going to make it. Obviously, this is not applicable to someone who is young or trauma patient or potentially reversible. That probably more applicable to those who already have got comorbidities, and you are thinking of giving them an ICU trial or something like that. And then once you get to that level, then you really have to stop. On the other hand, there's really, in the literature, there's no limit to how much vasopressors you give, especially, as I said, in someone who doesn't have comorbidities. And we have seen, or I'm sure Nabil has seen, I have seen people having their fingertips, amputated, necrosis of the tip of the nose, and they came back to the ICU walking to wave us goodbye before they left the hospital. So you need to take things into context, but really, once you've exceeded 0.6 mics per kg per minute, leave of it, and there's no reversible cause, and the patient has got multi-organ failure state, then that's the time I would stop. Thank you very much.
Thank you for adding that comment for us. I'm going to pass over Dr. Talal Dahan's with us tonight, and he's got a question to ask you as well.
Elite and elegant presentation, Dr. Abu Shala. Thank you so much. I wanted to elaborate on a problem I think that we have in critical care for a very long time. I don't think we have defined sepsis well. I think the trials have been either too specific or too sensitive to define sepsis. And based on that, I still struggle with the outcomes that we look at in clinical trials. If we don't know how to define sepsis well, how can we apply therapeutic measures? So I completely agree. Q-SOFA score was probably too liberal. It'll be probably everybody who's critically ill will receive sepsis management. At the same time, looking at SIRS, as we know from the ANZEX group back in 2015, we are gonna miss at least a good portion of patients who have severe sepsis. So I don't know, how do you feel about the latest recommendation on going back to SIRS criteria, while really back in 2018 or so with sepsis 3 definition, we were too sensitive? What is really the right definition that we should use?
I'm not sure. I mean, I can really add to it. I mean, I'm sure there are great minds that are looking at this far beyond what I can think of to find, a better way to identify patients with sepsis. My approach is that if you think about it, cover it, but be bold enough later if the patient's not septic to stop the antibiotic. So I would err more on, I've seen quite a few patients that come where people think they had acute MI, they had a PE, or they had something else, or they have altered mental status, they had a stroke, and there are things that don't match up, and I think the patient may be septic on top of it. And I usually err on covering them, but would be a big caution is that doesn't mean you're going to throw antibiotic on every patient that comes to you, but anybody that you have this lightest suspicion, I would not to miss these patients. I'd like them to be, covered. We know that the only difference is going to be is whether to add or not to add antibiotics. But you always have to be also cognizant that I'm going to stop antibiotic after 48 hours if I know this patient is not septic. And that probably would be a defensive mechanism, but if you make it more of a guideline or recommendation, then people may abuse it. So it's I think the best thing is good training and antibiotic de-escalation strategies, and so people can even if physicians would do this, and then the de-escalation team would contact them and say, okay, I think that you don't need to do this, then I think we'll be able to catch most patients. But I don't know if there are other parameters or cytokines or blood tests that are coming up in the future that would help us to identify these patients early.
Thank you, Dr. Nabeel.
Thank you. Another question in the chat, and again, if you're going to cover this in your next session, don't worry, but what is the appropriate time to start inotropes?
Well, I think I've discussed that. I think it should be started in the first hour. If the patients, after the patients, and the patient doesn't have to finish their first liter or 2 liters, but I like to get it particularly with those patients that have a diastolic pressure less than 40. Those patients, a lot of the papers recommend that we start them very early in vasopressors, even if we just started the IV bolus. But if they're diastolic less than 40 and they don't look too bad, and they, it's like a combination. I look at their, are they mottling? Are they hypoperfuse? Do they look confused? Or are they, some patients come in hypotensive, but they can still talk to you and look comfortable. Those patients, I would hold off on vasopressors. So it's a sort of a decision with bedside assessment.
Okay, thank you. I think we had another hand up from Ali.
Yes, but the question is answered. Thank you.
Lovely, thank you very much. Okay, the next question in the chat. If angiotensin II is available, would you use it before norepinephrine?
I'm sorry, say it again? Is it, did you say vasopressin?
Sorry, angiotensin II versus norepi.
Okay, I think the angiotensin II trials have not shown any additional benefit. There's only, I think, 1 or 2 papers published when they were compared. There was, I think the cost is tremendously higher, and I don't see any advantage of angiotensin II. I think there's more data about adding vasopressin to levofed. There's only a couple of papers, and I don't see it's really widespread. I don't think it's even available in most of the hospital I work at because of lack of data. So it has probably the same advantage, vasopressin not causing any tachycardia. But I think as far as, physiologically making or something in difference in outcome of patients, I don't think I see any advantage.
Thank you. Do you have time to answer a few more, or are you pushed?
I think I may probably have to, you have no idea how many pages I got. And I know Dr. Carol has been helping me in taking care of some of the urgent issues. So, but I think we can do some more answering questions. I'm hoping in the part 2, which is going to be next week. So it won't be too far. We look forward to having everybody who can attend next week.
Well, that's great. There's some good questions remaining in the chat. So if people can remember them and ask them again next week when we have a little bit more time, that would be great. But for now,
I want to say if Dr. Kerala, Dr. Talal, or Dr. Hassan wants to answer some of these questions, you'll be feel free. If you're Mazen, you can decide.
Okay. Well, thank you so much for joining us, and hopefully you get your pages all answered. But we appreciated the chat tonight and just how much work you put into those lectures. So thank you, and we'll see you again next week.
All right. Thank you.
Thank you, everyone.